Okay, well, what a great speaker and a great study to follow. Nasser's work is really just incredible. And as a surgeon in practice, it's truly remarkable that he was able to put together a randomized trial like that. Um, this talk is about defining local recurrence and what treatment strategies are available. And I think apropos of Dr. Al-Turki's talk, we'll go over some of the critical studies that lead to our understanding of the risk of local recurrence and what our options are. Again, I have a disclosure that I serve as a proctor for Intuitive Surgical, but otherwise have no other disclosures. So trends in lung cancer care and stage, as you can see in this recent report from 2022, since the advent of lung cancer screening and probably just with better CT scan available, the percent of localized stage lung cancers diagnosed and the survival at 3 years for those cancers has increased quite substantially from 17% in 2004 to 28% local stage of disease at the time of diagnosis, with an increase of survival of 21% to 31%, which has a lot to just do with the imaging modalities we have available, because our surgery really hasn't changed dramatically in that time. But there's always been a concern, and Nasser's study was so important to do because up until that point, the controversy whether a lobectomy or a sublobar resection should be done for an early stage cancer had not been answered. And one of the most foundational studies that was done was Ginsberg trial, the lung cancer study group randomized trial, looking at sublobar resection or lobectomy for early stage lung cancer. And they included patients, and they diagnosed their patients very differently. So they included T1 patients less than 3 centimeters. And these patients were diagnosed based on chest x-ray, not on CT scan. So you can imagine the type of cancers that they were seeing. Limited resection was done in 122 patients with a 2 centimeter margin. And segmentectomy was also done in patients. They defined recurrence, local only being ipsilateral lung or mediastinum. However, that definition and that data point was not used in their analysis. Local regional recurrence was defined as relapse at or near the primary site or in lymphatic drainage areas, either bronchopulmonary or mediastinal. And then non-local was anything after that. And the critical thing that they found was that overall in the limited resection group, there were 38 out of the 122 patients that had local regional recurrence. And in the lobectomy group, only 23%. So that fundamentally means that there was a 31% recurrence rate in the limited resection group. And of those, 17% or 21 out of the 122 were local recurrences. And the local recurrences actually accounted for 55% of all the recurrences in the limited resection group. In the lobectomy group, there was 23 out of the 125 patients had recurrence, or 18.4%. So they published the data doing a rate per person year, which you can see as 0.1 versus 0.057 in the lobectomy. And so their conclusion was that there was a 75% greater chance of recurrence with limited resection compared to lobectomy, also with a trend towards decreased overall survival. And that was sort of the nail in the coffin for limited resection for many years, and as a surgeon who sort of trained in the early 2000s, this was still the dogma. The gold standard therapy for early stage lung cancers was considered lobectomy. And if you did a limited resection, that was considered a compromised operation. And they postulated in the study that recurrence was due to incomplete clearance of tumor in the lymphatics and microscopic disease in the parenchyma. But as we know, with the excellent discussion that Nasser just did, that overall survival and disease-free survival with sublobar resection, when done in a controlled fashion, in a randomized fashion, in a modern fashion with CT scan looking at tumors 2 centimeters or less, shows that there's really no difference in survival when you do a limited resection. And obviously the quality of life and preservation of function is much greater in limited resection. As Nasser also alluded to, there was a significant amount of recurrence in his study. And over their 10-year study from 2007 to 2017, with over 1,000 patients registered and 697 randomized, in the sublobar group, there was about a 13% local regional recurrence rate, as he said, and an overall recurrence rate of 30.4%. In the lobar lobectomy group, there was a 10% local regional recurrence rate and a 29% rate of recurrence overall. So these are substantial numbers, not insignificant rates of recurrence, no matter what type of surgical procedure we do. And when we want to, contemporaneously in 2014, other randomized data was looked at. The I-ELCAP Z30 trial, which was really a lymphadenectomy study, was also then looked at in terms of a secondary analysis to see what the survival and recurrence patterns were based on tumor size. And from that, their definitions of local recurrence were adjacent lung parenchyma, bronchial stump recurrence, or hilum adjacent to the bronchial stump. Regional recurrence was considered hilum separate from the bronchial stump, mediastinum, chest wall, and ipsilateral pleura. Distant recurrence was defined as ipsilateral lung in a separate lobe, or anything contralateral or supraclavicular outside the region of that hemithorax. What I wanted to do was also look at what the recurrence rate were for other standard treatments or other experimental treatments for early stage lung cancer. So we looked at the Timmerman data from his RTOG trial, and they have a slightly different definition of recurrence. So local failure is considered radiographic recurrence in the local tumor bed of the same lobe. Regional recurrence is considered hilar, mediastinal, supraclavicular, and distance is anything outside of those defined locations. So they're really not that different from surgical definitions. In the past, there was a lot of controversy and debate between surgeons and radiation oncologists of whether we were defining the same problem. But when you look at Timmerman's study, the I-ELCAP Z30 study, Nasser's study, and the lung cancer study group, the definitions of recurrence are relatively similar. And what we see here based on T size, so there were 542 patients in the I-ELCAP trial that had T1 disease, 409 that were T2, and in the RTOG study, there were 55 patients. And when we look at the recurrence rates, the total number of recurrence, whether it was local, regional, distant, or a combination thereof, there were 23% recurrence rate in the T1 patients, 38% in the T2 patients, and 64% in the SBRT group. So what we can conclude, from that study is that recurrence rates for surgery increase significantly with increased size of the tumor, and also SBRT unfortunately does not provide, in our surgical opinion, the same amount of local control. So what are we doing for patients that have local recurrence? This is a question that I didn't have a great answer for, and I was able to find this study that Ben Kausauer did. He was actually an author that I quoted before looking at cost effectiveness of robotic surgery, and he's on faculty at Washington University in St. Louis. So this was a national cancer database review, which was really, part of the American College of Surgeons Committee on Cancer program, and we're a member of that Committee on Cancer credentialing process. And what they do is they abstract cancer cases done from any participating institution to look at the synoptic pathology reports and operative reports to see if quality across the American Cancer Society accredited programs are up to date. So they were able to look at the data accumulated from the abstracting process, and they looked at patients with stage 1 through stage 3 disease from January 2006 to December 2007. So it's a total of a 2-year period, and they were able to accumulate data on 9,000 patients. So 9,000 patients were identified and all had surgery with curative intent. Patients were followed for 5 years until their first recurrence or death from a new primary or recurrence. And the data was then collected and analyzed in 2015. Local regional recurrence was defined as ipsilateral lung or regional lymph nodes for this study, and distant recurrence was defined as disease outside the ipsilateral chest. What their data shows is that in this cohort, 67% of the patients were stage 1. 80% of those patients fundamentally underwent a lobectomy, so many of these patients did not have sublobar resection. About 1,100 patients, or 12.3%, had local regional recurrence, so that's a 12% recurrence rate for stage 1. That is local regional recurrence. And believe it or not, it was almost twice as many patients had distant recurrence. So for the stage 1 patients, it was 10.5% rate of local regional recurrence, or 15.5% risk of distant recurrence. For stage 2, there was an increased risk of recurrence to 16.2% for local and 30% for distant. And stage 3 had about a 16% local recurrence rate and almost a 40% distant recurrence rate. And when they looked at what type of treatment was obtained, the types of treatment that were most commonly used was actually chemotherapy. So of the patients who received active treatment, there were 812 patients, or 80% roughly of the patients who recurred received active treatment after that diagnosis. And 35% of those patients had chemotherapy, 31% had a combination of chemotherapy and radiation, 20% had radiation alone, and surprisingly for local recurrence, only 12.8% had surgery involved in their care. And what was interesting in this study is that they found that what were the reasons why people did not get any active care after the diagnosis, and substance abuse, symptomatic recurrence, or recurrence in the ipsilateral lung were significant factors for not undergoing any further treatment after recurrence. But what they also found was that survival post-recurrence was obviously much better in the cohort undergoing active treatment. So median survival after recurrence was about 20 months for those undergoing active treatment, whereas it was only 4 months for those who got supportive care alone. And the 5-year survival, unfortunately, was only about 11.4% for active treatment patients versus 4.8% for supportive care patients only. So in conclusion, unfortunately, recurrence rates after curative surgery are still quite significant. Definitions of recurrence differ from study to study, but they basically define similar anatomic regions and a similar problem. Surgery protects better than SBRT for local recurrence. Yet recurrence rates after surgery, even for early stage disease, is greater than 10%, reaching upwards of 30% in many studies. And that, that's what Nasser just said. So active treatment with chemotherapy, radiation, or surgery provides significantly better survival compared to supportive care, but survival overall is still poor. And as you'll hear from my chair, Dr. Flores, later, despite the controversy over newer therapies, including immunotherapy, rates of recurrence and survival post-treatment for recurrence necessitate ongoing trials with multimodality therapies to improve these results. I think it's pretty obvious that surgery alone for even early stage disease still carries a significant rate of recurrence, which then imparts a significant rate of mortality. So investigation into multimodality therapy in early stage disease, I think, is essential to improve overall outcomes. Thank you.
Thank you, Dr. Kaufman, for summarizing this very difficult topic for all of us. there is an extreme variability, as you said, in the definitions of local recurrence. Some of those recurrences might well be new primaries that we cannot sometimes distinguish. And the idea that we could and should do something if we can is certainly very, very important to all of us. Other comments from the audience?
Oh, yeah. This is sort of a follow-up to your comment about whether the recurrence is the initial tumor or whether it's a de novo tumor. And what is being done to try to sort that out? Are people trying to use molecular markers to distinguish between the initial tumor reappearing versus a second primary that's the cause of the problem? Thanks.
Would you like
Yeah, I think that it's a combination of good old-fashioned histopathologic analysis. So it's our practice at our institution that tissue sampling as much as possible is always done. We do reflex genetic sequencing, so next generation sequencing on all our cancer specimens. So we combine histopathologic data. So does the cancer actually look the same under the microscope? And also, you know, we rely on David and Claudia quite a lot. Radiographically, what does it look like? Does it look like a new primary? Does it look like a recurrence? And then we also do go to the genetic profile of the tumor to see if we have matching genetics. And we're pretty successful, I think, in defining what a recurrence is versus a new primary. And I think it's, you know, most likely because we have such a strong radiographic history for our patients because of Claudia and David's program, and we know what these tumors look like. And we can identify new primaries very easily as well.
The question is about when you have a distant recurrence or a distant metastasis, do you also seek to determine whether it is identical to the tumor that you've had as your primary that you resected?
Yeah, absolutely. So we
You find
compare.
that it is when you.
In most cases, absolutely, yeah. And thus that gives us the ability to give the diagnosis of recurrence, correct?
This is one more question from.
I'd rather comment coming back to the non-solid lesions, because we are talking about that in context of lung cancer screening. And there are several studies. I have looked once at several studies on veg resection and the recurrence. And in most of them, of course, they are showing no recurrence and 5-year survival 100%. The A1 study, when the Japanese authors, I don't remember who was the, probably Noguchi. I can dig in my literature, but he showed that, okay, after 5 years, no. But if you come back in 10 years or 15 years, then you can see 15 to 20% of recurrences in non-solid adenocarcinoma.
The problem with non-solid nodules is that number one, often they're multiple and you don't even see them in the initial CT, but they're usually separate. So I think it's very tough to call a non-solid recurrence for that reason. You really have to carefully look through all of the images, make sure that you had good thin section images to begin with, and then usually you see the nodule was there separate from the cancer that was taken out.